me just sort out this thing.
By the way,
Yeah.
did anybody notice that there is a clinical trial named after her?
Yeah,
Yes, I was wondering if anyone was
Yes.
At school, they called me Rika Dick Maria. So I don't like the referral to my name. So yes, thank you for the invitation to speak on radiotherapy. A lot has been said. A lot of the work has been done in terms of understanding HER2 disease. And specifically the role that radiation plays. And, you know, it has been, I think, pretty much set in stone for decades, but now we are moving in an area where there's more and more neoadjuvant chemotherapy prescribed. And that leaves us with what to do in terms of radiotherapy, depending on the response. And I think we all realize how important the response is. So in this ESMO guideline that we've got here, you can see, I'm going to try and see if I can use this. Where do I get the pointer?
Yeah, move it and don't roll it. Ooh. Sorry, don't roll it. Just
okay.
Very
lazy.
Point.
Okay, so if the tumor is small, a T1, and it's node negative, this is where we go for upfront surgery. Knowing that when the tumor is smaller than 5 millimeters, obviously this doesn't happen, all the extra chemotherapy and stuff. But if it's a proper stage 1, and if for some reason a stage 2 or 3 has been operated, for instance, only realizing the positive nodes afterwards, or getting that referrals of patients that had been operated already. In that particular case, we dealing with the stage 2 and 3, and the neoadjuvant treatment is very important. But this is a small part of our HER2 population. A lot of these patients present with large tumors, they're more than 2 centimeters, they're node positive. Those patients should get neoadjuvant therapy. This is the standard for all node positive patients, all HER2 patients, stage 2 and 3, and all triple negative patients that is larger than 2 centimeters. And then when you have your complete response after surgery, neoadjuvant therapy in surgery, we have to decide who benefits from radiotherapy. We've seen the fantastic results of the anti-HER2 targeted therapies. Does that change the indication for radiotherapy? Now, upfront, I know that everybody will agree, if you don't have complete response of the neoadjuvant therapy, those patients do qualify for radiotherapy. But can we do risk-adjusted radiotherapy in those patients? And in terms of having a complete response, is there any benefit? Who are the patients that should then get radiotherapy? So that is the difficult question. Now, this is the old Oxford overview. This is back to basic. As Etienne mentioned, we know that in the top block over there, this is not really working very well. Let me just see if this is perhaps working. If I, no, not working. Okay, so let's go here. So in the top block there, you can see that patients with node negative disease, if they receive breast conservation surgery and they receive radiotherapy, you can see at 10 years, the disease-free or recurrence is half, 30% without radiotherapy, and about 15% if they haven't received it. And on the block on the right-hand side over there, you can see the overall survival benefit. In node negative patients, it is less. in the bottom block, you can see the benefit of patients that have no positive disease and they had breast conservation therapy. Well, the difference in these patients are larger, 21%, and you can see a significant change in the overall survival. So node positive, and this is for patients receiving those group that receive adjuvant surgery upfront. This principles still is the same, never mind the type of breast cancer that we have. The question is there any data where we have a very early stage breast cancer? Can we omit radiotherapy? Just like Fatima asked the question, can we leave surgery? Now, this is a retrospective study where they looked at T1 in Node HER2 positive patients. A lot of patients, about 6,900 patients were identified, the US trials. The patients had their surgery, proper surgery, and they had their anti-HER2 therapy. About 500 patients of that study group didn't receive radiotherapy. Now, the reason why they wouldn't receive radiotherapy is because the old story, they're more than 70 years old. Half of the patients refused radiotherapy. A big portion of the patients was poor patients, far away from radiotherapy options. And in America, they've seen that patients of color also received less intense therapy. And that led us to this particular follow-up. The mean follow-up was about 30 months. And what you can see here, when you look at the multivariate analysis, are you going to try and get me that?
I can't get it. Here we are.
I'm very sorry.
30, small.
Yeah. So, okay, I'm going to see if I can get it. So, it's very slow. Look here at the multivariate analysis. Radiotherapy versus no radiotherapy gives, even in this very stage 1 small tumors, a significant benefit. So no, we cannot leave radiotherapy out. What about the 70-year-olds? 70-year-olds are not old anymore. The average age of the white women in South Africa at this stage is 84. So not radiating a patient that is 70 years old doesn't make sense. And you can see those patients had almost a double and a significant increase in relapse. For the patients with hormone receptor positive HER2 tumors, and they haven't received their hormones, the risk is, the hazard ratio is 3.33. So the combination, the taking all these factors in consideration, we have to see HER2 positive tumors always as a high risk. They do not fall in the group where we're trying to leave radiotherapy, like in the low-grade elderly patients with strongly hormone receptor positive. This population doesn't fit in it. In the small tumors on the left bottom, you can see a less than small 1 centimeter is maybe a smaller benefit. But the moment when the tumor is more than 1 centimeter, and the majority of these tumors with T1C, so they're close to 2 centimeters, you see a significant benefit in radiotherapy. Should we boost after breast conservation therapy? This is an old study, the ERTC trial, that showed that yes, boost is always better, but it's better for certain patients than other patients. And age was the critical factor here. And we ended up agreeing that over 60-year-old patients, we don't need always to radiate with a booster. But in the younger patients, living longer, often have more aggressive disease, in those patients, the boosts do have a huge impact in outcome and eventually in overall survival as well. I like this slide in terms of the boost recommendation. Now, the Oxford overview, the ERTC group, is mentioned there as reference in terms of the level of evidence, and the HEO is the German breast cancer study group. So what they say is boost. The small benefit that we see is mainly in local control, and all premenopausal patients should get a boost. But what about the postmenopausal patients? The postmenopausal patients with high-risk factors, and here they say triple negative, HER2, grade 2, big tumors, extensive intraductal carcinoma, a big tumor, those patients should actually get the boost. So it's an easy, adjustable, and I think at this stage the right treatment for these patients. And then they talk in the techniques in terms of sequential boost or incorporated boost. I tend to go with sequential boost because of the poor cosmetic outcome that we have, and we never are able really to give a nice controlled boost to volume. There's always shadow with a higher dose to the rest of the breast, and that compromises the cosmetic outcome. So having a sequential booster is better cosmetic, no impact on overall survival, so don't rush into that. Now, the post-mastectomy radiotherapy, we all know what was the old, or let's say the traditional recommendations. It is patients with a T3, T4, a patient with node positive, and it was the 4 to more than 4 nodes positive. Those patients had to receive the radiotherapy, and you can see here at the top the recent incorporation of patients with 1 to 3 nodes positive. So what this trial said is, never mind whether you have nodes, how many nodes are involved. If you had post-mastectomy surgery with an axillary clearance, those patients with nodes positive should receive radiotherapy. And you will see in the A block there that the difference there, the benefit in local recurrence is quite high in this patient. First recurrence and the breast cancer mortality, C. Now, in the bottom, you see the benefit of local therapy in patients with more than 4 nodes positive. Locally, there is a huge benefit, but actually in the any recurrence or the breast cancer mortality in the bottom area, you saw less benefit. So we kept on thinking the more nodes, the worse it is, the more important the radiotherapy is. But here we see the very important interaction between local control in the breast and the most effective systemic therapies that we get. So in the 1 to 3 node positive group, the benefit of the systemic therapy is driving the huge overall survival. Huge. And in that particular group, we should not step back in terms of radiotherapy. In that specific group, the local control by proper radiotherapy, not sloppy radiotherapy, drives the overall mortality benefit for radiotherapy in this group. So I want to point to that particular group, the 1 to 3 node positive group that had a mastectomy, and the benefit in that particular group of patients. So regional irradiation after the mastectomy is now we're asking the question, how wide? Internal mammalian, the rest of the axilla, the supraclav. I think it's important to understand that wide field irradiation is important in those patients with those biological features, less than 40, ER positive, negative, HER2 positive, grade 3 extensive lymphatic invasions. In those patients, think wide irradiation. The supraclav specifically, in those patients that you can see there's a small benefit, and it's only when you really combine it with the internal mammalian glands, but it is a standard to add it to the 4+ node positive group or the inflammatory group. And it's recommended in the 1 to 3 nodes positive. And you never irradiate the axilla that was resected. You always add your radiation above the resected axilla. So the question is, in this small group of 1 to 3 node positive, where we do radiation, is the supraclav necessary in that group? We don't know. There we have different opinions. What about the internal mammalian nodes? Again, only a small overall survival benefit. And it is not in different study populations, the benefit of that is on a different level. But the biggest benefit was seen if you had a lot of lymph glands, if you had a medial tumor, specifically if it's a T2 or bigger, or central tumor. But don't underestimate the cardiac toxicity, the mortality that we forfeit when we radiate patients on the left side. But again, regional irradiation mustn't go out of fashion for those high-risk patients that we see, the very young, the ER negative, HER2, and the extensive lymphatic invasion group. So this is post-mastectomy. The difficult and the unresearched area that we have is radiotherapy of the neoadjuvant chemotherapy. And as St. Gallen is reflecting a different opinion when you listen to the panel, you never get like almost 100%, especially in a field like this. Now, this paper is by Ung from the German group. And what they did, the St. Gallen of 2021 was summarized. And they had a critical review of the recommendations of the St. Gallen. And they compare it here with their own recommendations. So in this group, radiotherapy, when is it indicated after neoadjuvant? Always in locally advanced disease. What does it mean? It means a T3 or a T4. It means a lymph gland, a T2 or a N2 or N3. So locally advanced disease still need radiotherapy. Your clinical assessment with your surgeon, with your reconstructive surgeon, is why you would radiate. And if you want to do risk adjustment in your fields, you should have seen the patient with the surgeon, with the reconstructive surgeon. You've got to understand what surgery is done, what reconstructive surgery has been done. So what if we have a smaller tumor, T1, T2, and clinically those patients had a node positive, and you can confirm it or not, with an ultrasound, with a needle biopsy, with a PET, different ways. And after neoadjuvant chemotherapy, there's still a positive node. Those patients should receive radiotherapy, and they should receive local as well as the regional lymph glands. Now, what if the patient had a T1, T2, clinically node positive, go through neoadjuvant therapy, and now, at the time of surgery, the node is negative? What now? That particular group, in the majority of the St. Gallen recommendations, said that they don't see why we must radiate all those patients, and we should have a risk adjustment type of approach in those patients. And obvious, if the patient was a T1, T2 node negative before chemotherapy and afterwards they had a complete response, the radiotherapy is only indicated in the breast conservation therapy. So there was about in 60% of the panel agreement that in those small primaries, node negative, complete response, resected as breast conservation or mastectomy, local radiotherapy in the mastectomy group is not always indicated or any benefit. But we have to, again, look at the high-risk group, and here pre-treatment high-risk group is again what we've seen, as with the mastectomy group, a grade 2 or 3, ER/PR negative, premenopausal, and I want to add the HER2 group here, which I believe should be part of them. So, what are the factors? If you had neoadjuvant chemotherapy, you had your resection, and you had your radiotherapy, what are the factors that increase your risk for local recurrence? There you can see that in color, the impact of age, less than 40 and more than 40. Also, the difference in subtype. And you will see at the top, the highest risk is with the triple negative breast cancer. This publication is from the Indiana Memorial in Sloan Kettering in 2018. And what was interesting in this particular group, the patients, the triple negatives had by far more relapses. And the area of local relapse was in the majority in the internal mammalian lymph nodes. And I've seen it in our practice as well, that at one stage, we moved away from the internal mammalian gland chain if you had a complete response or few lymph nodes in the axilla. But in the triple negative group, wide field irradiation is still very important. If you look at the pathological T, obvious, it's clear, the bigger the primary initially, the higher the risk. If you look at the grade, we see the more aggressive tumors, and then the surgical margin. And I apply this rule. If it's negative, the risk is really low. But any margin less than 2 millimeters, to me, is a strong indication with any other high-risk factor, like HER2 positivity, I would really consider treating the chest wall or a boost in that particular area on the scar or the chest wall. It's not standard to add a booster on a mastectomy scar. It is only in those patients where a very close margin was seen. So these are the factors that we need to use when we individualize our treatment. This study looked at the same question. Doesn't matter the different types of breast cancer that we have, done by the Dane in surgery, Monica Mara, and they had about 223 patients. Now, in the first graph, you can see that the top line is a hormone receptor positive subtype, and the recurrence after the patients had neoadjuvant, they had the proper treatment. The risk for the hormone receptor positive group is much lower than the HER2 positive group. And as you can see in the triple negative group, the graph on the right-hand side is showing the same population, but where complete responses was not seen. And again, massive increase in the triple negatives, but also significant in the HER2 if you don't have a complete response. And it's even more a problem if you have not a complete response in the lymph gland. That carries a higher risk for the patient. So I think we have to accept that there's data indicating that the HER2 radiotherapy approach, you should see this as a high-risk factor on its own. This question about patients that had a complete response, do they benefit from radiotherapy or not? And this is the ongoing trial, the NSA-BP-B51 and the RTOG group 1304. Still, we don't have any results, but in this particular group, they say clinically, these patients had the T1 to T3 and a node positive. And when they had the neoadjuvant therapy and surgery, that node became negative. So the question now is, do they benefit from radiotherapy? And they divided the patients in breast conservation and mastectomy that receive radiotherapy or not. And this is the only prospective study that will give us a true indication who are the patients where we can step back in terms of their radiotherapy. In the HER2 group, in this particular trial, they were supposed to have the proper anti-HER2 therapy. And I think this is a very clever study and I'm waiting for this results. Hopefully, we will be able to decrease our radiotherapy indications. Now, the second thing is, if you use neoadjuvant therapy, the most problematic group of patients for radiation oncologists is the group that receive the reconstruction. And again, this is from the German group, and you can see on the left-hand side, we quickly ask the question, is this patient going to need radiotherapy or not? And if they have no radiotherapy, they have a lot of options. They can have a skin sparing mastectomy, a nipple sparing mastectomy with the implantation, or they can have a tissue expander with the implant later on, or they can have own tissue reconstruction. It becomes trickier when we know that radiotherapy is going to be a problem or an indication. And in our, the options that the German group suggests is a mastectomy with radiotherapy and delayed reconstruction. A lot of problems in this particular group, and we, I can't remember when last did we have a patient going this way. In the majority of the patients, we use immediate autologous reconstruction. The problem that we have is the fat necrosis due to surgery, and also the capsular formation in that particular group. But if we use an expander here and radiate and then put in the silicone prosthesis, the side effects are really a problem. If the patients are not suitable, they just don't have enough fat donor sites to have own tissue, or the patient doesn't want to go through surgery of 6 to 8 hours with much bigger wound areas, then a prosthetic reconstruction can be offered to the patient. Now, it can be the two-step one that I've mentioned. You put in a spacer, radiate, and then later on you can put in the proper prosthesis, or you can go immediately with the right prosthesis. And what we've seen is those that get spacer and then they go for radiotherapy and a replacement like that really have poor outcome in terms of satisfaction. This is a very neat study looking, this is patients that reported. It's a prospective study, which is great. And they looked, asked the patients to report back. Now, you can see in terms of the breast, the patients that really had the best outcome, and this was after a follow-up of 3 to 5 years. I think I can't remember the mean time now, but the best outcome for patients was if they didn't need irradiation and they had own tissue, not a prosthesis. The second best group was, and they were very close, 63-67% of the patients were those that had own tissue with radiation. But as you can see, a radiated implant left about 50% of the patients unhappy with the results. Now, we know about the complications with a prosthesis, with the implant. And what was interesting here, so that was from the patient side, from the doctor's side, the treating oncologist team, you can see after 2 years, 1/3 of the patients had major problems, meaning that they had infection or a lot of contracture, capsular formation. Only 17% of the patients with their own tissue. And you can see the breakdown of the radiated and unradiated benefit there. The reconstruction failure was seen mostly in the patients that had radiation on the implant. Whether the own tissue gets radiation or not, there's no difference in complication, in major complications for these patients. For the radiation colleagues here, I just quickly want to remind you about the prosthesis implant and the different techniques that we have there, because that has got an impact on how you radiate your patient. On the first one, see here, you can see it is behind the pectoral muscle, and the whole prosthesis is covered by the pectoral muscle. Here, a part of the breast is covered. So the pectoral muscle was there, and there's a part of the chest wall here that is part of the subcutaneous and deep plexus lymphatic drainage area. And then on this side, you see here the pectoral muscle stays at the back, and the prosthesis is in front of the pectoral muscle. Now, it's very difficult to see this on a CAT scan when you do your planning. It is important that, and it's very valuable to go into theatre and just have a look, how these procedures and how the mastectomy is done to help you to visualize and plan these patients. So there were not really a lot of guidelines, but ISMO published this consensus guideline for the patients with prosthesis. And in this particular case, I hope you can see, I'm going to go here. The pectoral muscle, here it is. So you can see the prosthesis is behind the pectoral muscle. And in this particular case, the treatment volume, which is in red, I'm just going to show you there, is this particular volume there. So you treat basically anterior of the pectoral muscle in this particular group. You have to, on the medial and lateral side, increase a little bit more tissue. So this is ideal for a patient where only the subcutaneous lymphatics is the target for radiation. If you need to radiate the chest wall, and in this particular case, it would be big tumors, T3, T4s, a lot of lymph glands, or a tumor that is far back in the breast. In that particular situation, you have to take the chest wall in as part of your tumor volume. And here you can see the pectoral muscle is sitting there. This part, the pectoral muscle was originally here. So if you have to include the chest wall, this would be the target. And here you can see you have to include your medial tissue on the side. And on this cut, you can see that the chest wall, you can compromise on your volume in that particular case. Most of our patients get a prosthesis in front of the pectoral muscle. So here's the pectoral muscle. Again, you have to decide, do you need to treat the front of the breast, this subcutaneous lymphatics, or do you have to incorporate the chest wall at the back? Again, the red one is showing when you have to incorporate the subcutaneous tissue. And here you can see it looks a little bit different when you treat in front of the pectoral muscle. And here at the back, you have to treat the whole chest wall in this particular set of patients. So for different implants, there's different radiotherapy. And the back of the prosthesis is only included in very large tumors, treating by mastectomy in an implant, locally advanced with tumors that receive chemotherapy, and there's not a complete response, and invasion or closeness to the back of it. Now, at this stage, there's a lot of trials trying to completely exclude the prosthesis in the radiotherapy field. I don't know what that is going to cost, because radiotherapy is a very expensive thing, but I think it's going to take a while. Here is the problem that I have with the spacer. If you put in the expander, there's a high rate of reconstructive failure, about 1 out of 5, versus where you do the proper implant or the final implant immediately. But what they've seen is when they go in the second time, the capsule contraction was a little bit less than versus the radiotherapy in the final prosthesis. And I think that this relates to the data where most of the patients with prosthesis just get one shoe fits all, included everything in the field, not trying to do risk-adjusted radiotherapy. And I'm sure we will be able to do far better than what this is indicated here if we treat according to the ESMO guidelines. Obvious, last one or two slides that I have, is hyper-fractionation is now the standard of care. It started with the START-B trial. And here on the left, you can see the 10-year local recurrence rate was in the 50 gray group with a booster, 5.5, and actually 4.3 in the 15 fraction group with a booster. And if you look at the overall survival, you can see you do not compromise by using 15 fractions. Also, if you look at the breast outcome, there's less shrinkage, there's less hardness, there's less change in the skin appearance in the 15 fractions, there's less swelling, there's less pigmentation in this particular group, and it's now the standard. And a lot of people ask me, but what about the lymph glands and the brachial plexus? There's enough data to say this is now standard for the regional lymphatic radiation as well, and is suitable following reconstruction. In fact, better in some studies than the 25 fractions. One publication said that if you had wound infection, the collagen that is generated in the wound infection can actually aggravate the bigger fractionation group. So this is the only group where I have prolonged a wound infection where I wouldn't go for this, but in fact I don't give the 2 gray, I actually give the 1.8 gray, and it may be used now in patients in younger patients. Now, in that other group of patients where we have a very small primary, a T1, the next move is to give only 5 fractions, according to the Forward Fast trial, 2.6, 5.2 gray in 5 fractions. And at this stage, I only apply it to patients that receive breast irradiation. But I'm busy putting an advert together where I want to say fastest radiotherapy in town with the least out of money cost involved. Because I don't do 25 anymore, I do 15, and where I can, I go for 5 fractions in those patients. It has been studied and we have to move on. What about concurrent? Now, Herceptin is a radiosensitizer, 1999, 2003, preclinical studies, but it doesn't seem to increase the toxicity of the normal tissue. And even in the trials that was recently published, we see there's no permanent toxicity in terms of the cardiac toxicity, but there is a drop in cardiac function while you're radiating it. If you look at the small molecules, lapatinib, neratinib, they were only studied in patients with brain mets and radiotherapy, so we have far less issues. Pertuzumab, there's no impact on the heart. But with all these adjuvant therapies, don't interrupt your Herceptin or your pertuzumab. What the radiation oncologist must do is to make sure that you do optimal cardiac volume sparing and decide which patients must receive the internal mammalian gland radiation. Katsila, a little bit more side effects. There is radiation-induced pneumonitis, and there's also asymptomatic decline. The decline in most of the study is 10% points, but if you have a patient sitting on 54 ejection fraction, this is important. It recovers, fortunately. So radiotherapy is definitely going through a little bit of a learning curve again. It's not one shoe fits all, but good treatment guideline doesn't, will definitely not guarantee good outcome and clinical endpoints. It is the combination of the radiation oncologist, the surgeon, the medical oncologist, the reconstructive surgeon, those four that really integrates to the best outcome in all clinical inputs. Thank you.
Rika, you were on time.
Yeah.
And I'm so glad that you're fast now, that you're in the process of acquiring a similar fast as mine.
I'm going to earn less money with all those short courses.
Okay, now let's get serious again. I have one question that intrigues me enormously. We say neoadjuvant chemotherapy and biologicals, then surgery, then radiation therapy. But the cheese has been moved now a little bit. Radiotherapy after adjuvant treatment also, or should we do this, space this between the surgery and the adjuvant therapy? You know what I mean? When you have had an incomplete response after neoadjuvant therapy, should we do surgery plus radiotherapy, or should we first do the surgery, then give the adjuvant treatment with TDM1, and then only irradiate? Are there any data?
Well, if you look at the old trial that Irene referred, when you delay your anti-HER2 therapy, in that particular publication, the radiotherapy was also given concurrently with. So there's no data. I know that radiotherapy can be used before surgery, especially in those very like inflammatory breast cancers. But it's not something that I've done. I've done it only in very high-risk situations where I've given almost like a teaser, if I can put it like that, a 5.2 Gray fraction times 5 over the breast to improve local control and then move on to surgery. But in general, surgeons are not really keen to radiate those, to operate on those patients due to the wound in the poor wound healing and problems that we have. So in my practice, not something that I do.
Okay, questions from the floor or from the countryside? Or are we now running out of questions?
Yeah, we are now hungry.
I think Zoom should have an add-on to see if people's eyes are open when they are there, but we don't know. Yeah. So we don't have questions from the online community, but they are most welcome to tell us. From my side, Francois, you have a question as well. I think maybe just one issue about the whole prosthesis and radiation. I think if you look at all the literature around that, there are huge variations in what people report. It's almost always single center, usually 1 or 2 surgeons involved type of series. So there are no huge big series. As in most things, and I have to say this carefully, but the premier plastic surgery journal is not known for its intensive data analysis. It's usually more like pictures of patients' breasts and stuff. So I think the things that I can assimilate from all that data is, if you put your prosthesis or whatever you do, if you put it behind the muscle, you will basically almost double the risk of capsular contraction problems. So I think we have changed completely. In the old days, we used to say a prosthesis or an expander must have total muscle coverage. And I think that came from the plastics thought of, when you do that for augmentations in thin patients, then they have less capsules. But in reality, in radiation, we saw that it made it worse. So we would now put all our prosthesis in front of the muscle, unless you have someone that is exceedingly thin, but you really don't have choices. So I think that's first thing. The second thing that is still, it's reported, but the major thing is the use of early post-radiotherapy lipofilling. And I think if I look at sort of data now over the last 22 years and our experience, those 2 changes have basically halved the rate of capsular contraction post-radiotherapy in the use of prosthesis. So we, in our unit, don't use expanders at all. We put a prosthesis in because a prosthesis is half the price of an expander, plus you can't get expanders anymore. So it's cheaper. Number two is I am concerned about the scattering caused by the port in the expander in the radiation planning, because you have a piece of metal. So it's like irradiating a tissue next to bone. It is going to create a cold spot right there. So I'm concerned about that, and therefore, cost-wise, complication-wise, and from a treatment perspective, it makes sense to put a prosthesis in there. You need something that's going to keep the space. We don't expand breasts. Most of our women in South Africa have breasts that are big enough. Usually we have to make them smaller. So
areas in Cape Town where we still
I know,
that.
but what I'm saying now, from a unit that sees 350 breast cancers a year, this is what we've changed, and that has seriously cut down on what we see in terms of bad outcomes. I think that's the thing I want to contribute. And
one more thing. We can't do an MRI with those spaces.
Exactly. Yeah. So, and I think that I think has changed.
So all of the prostheses go in front of the muscle if we really can. We try and avoid expanders. We do lipofilling. So week 4 to week 6 after radiotherapy is when your tissue have a hyperemic phase. After that, it becomes a hypoperfusion phase with fibrosis. If you put fat in that phase, then you do two things. Number one is you've got good blood supply to the tissue. And number two is you putting in stem cells from that fat in between the normal cells. And I think there's now several publications that have looked at long-term outcome, which says it doesn't increase the risk of local recurrence. So, but it definitely increases the risk of recovery after radiotherapy for the tissue. So it makes the tissue softer. It makes the risk of dense capsules less. And I think that is something that from our side we have experienced as being stuff that we interact with the radiotherapy very closely.
So then do you guys put a smaller prosthesis in if you're going to anticipate lipofilling?
No. Okay, so I think we discussed the issue of autologous versus I would call it staged tissue reconstruction versus prosthetic reconstruction. So if someone wants to say, I would eventually like to replace my prosthesis with lipofilling, but I don't want to have a 14-hour operation, then we'll do something like that. So I don't want to lose volume, because with radiation you're going to have less tissue, stretch. I'd rather put a prosthesis in that fills that whole space and later change to a small prosthesis. So for me, my thinking is, or our thinking is, we know there's good data that says an operation longer than 4 hours decreases your immune response and makes you more immune susceptible. We know that HER2-positive breast cancer is a disease that is driven by immunity. Part of the reason why trastuzumab works is because it elicits an immune reaction. So I am concerned about doing a 12-hour operation in a primary care setting. I don't talk about a patient that's already cured of a cancer, but I'm talking about someone that's just finished radiotherapy or just finished chemo, might have residual disease. You've got a window of treatment opportunity, and now you're exposing the patient to a very long operation. So the idea is to say reconstruction is a process and not an event. You don't come and have a reconstruction and then you're done. Actually, no one does that. Even the autologous reconstructions need to have adjustment operations later on. So the reality is to say, I'd rather do a 2-hour operation. So if we do a bilateral mastectomy with prosthesis and a BSO, that's 2.5 hours. So I'd rather do a 2.5-hour operation and then do another half-an-hour operation 3 months down the line after the radiotherapy, and do another 45-minute lipofilling session 6 months down the line, because all those small procedures makes no impact on the patient's immune system and doesn't impact on the cancer treatment for the patient. So, but the patient doesn't walk out there with a flat chest. So it's a different way of thinking about reconstruction. Instead of saying, like in the old days, you are going to have a reconstruction, it's saying we're going to put a foundation there and we are going to give you a reconstructive process to end up with a good result. And I think that is maybe a different way of looking at how we think about reconstruction.
Yeah, I mean, we've also moved away from putting expanders. And if you're going to do a better, I think, then to do a delayed autologous reconstruction, because some of those patients might be happy with their implants and say, no, I don't want this operation anymore. And others might say, okay, well, take this thing out. I want a flap. So it gives you those options. We don't put a lot of expanders anymore, except for really high risk patients. But what you do need to understand is if you add radiotherapy to recons, it doesn't matter what you do, you're going to have a higher complication rate, and the patients need to understand that.
From our experience, and we've done more than 1,000 reconstructions with own tissue. What we have seen here represented in the presentations here, actually our treatment is very good. Yeah, and that covers radiation, that covers medical oncology, but I want to specifically refer to surgery. And most of you will not be aware, but I started my career in cardiothoracic surgery, and we measured the perfusion to the internal mammary artery. And that gives you a perfusion of about 120 milliliters per minute. So if we're doing a DIEP flap, it means we have a very well perfused reconstruction, and we get a minimum of radiation complications. This is part one. What we have seen here are figures that I would think contain other known inferior types of reconstruction, like, for example, tram flaps, like, for example, LD flaps, and these are counted as own tissue. These are inferior. Number two, I think it's a myth that the DIEP flap lasts 12 to 14 hours. In our hands, we're currently rolling it out in between 4.5 and 5.5 hours. Then the DIEP flap is in. There's no evidence whatsoever that own tissue reconstructions have a higher recurrence rate than prosthetic reconstructions. Last but not least, from Breast Surgery International, which is a global association of surgeons in breast cancer, we have come to the conclusion, no matter where you go, if you have a staged reconstruction, staged types of cosmetic procedures where the patient has got to go back to theater and go back to theater and still one more, have got a very poor acceptance rate. And we find it that, and there are enough data to confirm that, that only about 40 to 60% of patients, depending on where you go and how you motivate them, actually come and end this program of staged reconstructions. And my favorite anecdote of this that exemplifies this problem that our patients have is that one of our patients is a very prominent breast cancer advocate who had a bilateral mastectomy and early flap reconstruction way back. I won't mention any names here. And I regularly meet her in front of radio studios where we go for Breast Cancer Awareness Month, and then we meet and I say, hello, so-and-so, when are we going to make your nipples? And she goes like this, Justus, I've had enough surgery. The patients, once they've had their definitive surgery, they don't want to go back to hospital and have further surgery. And we must not blind it by our thoughts, how good we actually are. Patients often think differently.